Hi everyone, welcome to our third webinar of Starting Your Surgical Career. So this is a webinar series that's aimed at basically anybody who's thinking about surgery. The previous two lectures were recorded, as this one will be, and they'll all be on our website for you to listen to and look back on afterwards. We were supposed to be having a talk from Wesleyan, who are sponsoring this lecture series kindly for us. They're about financial advice for doctors and dentists, and I'm sure a few other professions. We don't have them with us today, unless they're joining now, but I don't think so. But they actually also spoke at the beginning of the previous webinar last week. So if you head over to our website on nsts.com and look at this career webinar series link, you can look up a bit about them there. But thank you to them for sponsoring us. Okay. So today's lecture is going to be by Miss Alice Gargan, because she's passed both parts of her surgical exams. She's just started her core surgical training in London. She is also on the NSTS committee, and we trained together at Leeds. So Alice is very well equipped to be taking this lecture because she did absolutely phenomenally in her applications and came in the top 2%. So this lecture today is going to be talking you through her kind of point of view of how to approach applying for core surgical training, especially during COVID times when you don't actually have a surgical job because you get redeployed. So without further ado, I'm going to hand over to Alice. Thank you.
Thank you, Jen, for a nice introduction. Let me know, I can't see the questions and things as I go along, but let me know if there are any. So yeah, as Jen said, my name's Alice. I recently started CT1 at George's, so I'm fresh off the application train. So I applied last year and I've just started. So I was in a similar position to a lot of you. I think we're going to do a quick poll at the start now, if we can. I'm not in charge of it, just to see what kind of year everyone's at, so I can have an idea of how to structure the session. Okay, so it looks like, great, predominantly medical students, a few FI1s, a few FI2s, and some FI3s. Perfect. So medical students are winning, which is great for starting early, because that's the most important thing to do, I found. Okay, bye-bye. So today I'm going to go through just a quick timeline of events, probably more relevant to the F1s, F2s, how to maximize your portfolio, which is what everyone always wants to know about, always wants to talk about, how to be efficient in doing that. And then tips for the interview, probably less relevant for med students, but worth getting your head around how to think about things early. And then there's one slide on exams, just so you're aware, those who might not be aware of how they work or what you need to do. I'm going to do, this is the third in the series. So head to our website if you want to look at how to maximize your portfolio in med school and how to maximize it in F1, F2. They're available on our website to watch. And from feedback from the previous sessions, we found that it was most useful to have an opportunity for questions and discussion throughout. So there's the chat option. If you just put your questions in there, Jen will let me know every now and again. I've got opportunities for questions. Okay, so off we go. So before starting to apply for CST, similar kind of questions you're thinking about F1. Is it more important where you want to be? What rotation you want to do? This is the one, the how to maximize my points is what everyone's always thinking about. What if I haven't decided my specialty? That's still fine. I'm a CT1. I'm still thinking about plastics, orthopedics, ENT, and I'll figure it out at some point, I'm sure. Teaching hospital versus DGH. Teaching hospitals are useful for things for your portfolio. DGH is useful for actually being practically good at surgery to get more opportunity. And then we'll go through what comes at interview, and we can briefly cover CST versus F3. There's benefits, there's pros and cons of both if people want to go through that, but I haven't got a specific slide on it. So firstly, what is core surgical training? So core surgical training is a 2-year training post. It can be, you can get a themed post or an uncoupled post. Don't worry, I'll explain that. It's a national selection process, so it's the same as F1, and your application goes through Oriel. The entry requirements are you need to have successfully passed your F2 year and have full GMC registration. If you have both of those things, if you pass F2, you have full GMC registration. I'm not too sure how it works for people applying from outside of the UK or from different posts, so I'd have to ask someone about that if we needed. It's very, very competitive, and it's getting more and more competitive every year. Last year, there were 4.6 applicants to every 1 spot. New thing about this year is they've removed, for next year, they've removed the run-through posts. So CST, again, probably just going to get even more competitive. So the themed posts, I'm on a themed post. It just means that the range of specialties that you experience are based around a theme. So for example, mine's plastics. I'll get a year in total of plastics over my 2 years. And the other specialties I try will be either, there'll be allied specialties, which means they will get me points and work towards beneficially because they're allied specialties. For example, I've got orthopedics and ENT. They not only will give you points for towards your SC3 if I wanted to do plastics, but they're also useful. Obviously, plastics and orthopedics are very closely entwined, so it's useful to have experience in both. The uncoupled posts are you apply and you just get a year, so you don't know what your second year will be. Sometimes this works out better actually, because you do have to go into a second application process for your second year of CST, but most people I know get their first, second choice. So sometimes you can end up getting a better set of rotations on paper than some of the theme posts. Okay, timeline of events. Now, obviously, don't quote me on these dates because these were my dates and they change every year, and they often change throughout the year because something breaks down. But roughly speaking, the advert will appear on Oriel at the beginning of November. You have to fill it out with your details, your previous posts, etc., etc. That closes in December. I'm going to go into more detail about the evidence portal, but this is essentially your portfolio. So what used to happen is there was an interview day. One of the stations would be your portfolio, one would be the clinical scenario, and one would be the management scenario. The portfolio the station was scrapped. I'm not 100% what they're doing this year, I don't think they are, but what they used was an evidence portal instead, where you did your self-assessment and you uploaded your evidence. So this is where you upload your evidence. So what happens is you rank yourself first. This is what I think I should be scoring in every single section. You put that online, and then a consultant, this is the evidence verification stage. A consultant looks at you and goes, no way, you don't deserve that many points, or yes, tick. And then that's when you find out what score you get. This last year was a bit of a disaster for lots of my friends because there's no way to defend your evidence, not like in an interview station. And also some people's evidence was just missed. For example, I got deducted points because for my surgical taster week, which said my feedback came back like, you haven't done a surgical taster week. And so I had to go through the appeals process, which was very simple, to be fair. And I said, yes, I have. And they're like, why are you appealing? And I go, because I've done a surgical taster. I've uploaded my evidence for a surgical taster. So please can I have my points for my surgical taster? And obviously they gave them to me. So it was fine. But lots of people, there was lots of unhappiness about this year. So this will bring me on to really, really clear evidence. Interviews happen around February. And it's actually quite a quick turnaround, 2 weeks of interviews. And then by middle of April, you get your initial offers. And then there's a bit of a period of people who don't take jobs and everything in the upgrading process. So surgical portfolio, everyone's favorite thing to talk about. So this time last year, I sat and I went to every lecture I could see, every advice, everything about the portfolio. And I found it very, very unhelpful to every session I went to, somebody just read out the assessment guide to me. So that's why I don't want to do that today. If people would like me to do that, please put it in the chat and I'm happy to flick through it. I've got it on a separate window, but I don't think you particularly need me. You're all clever medical students. You don't need me to read out a 30-page document to you. You can do it. I'll tell you the key bits. So the surgical portfolio counts for 1/3 of your total score for CST. The smart thing to do, everyone has a surgical portfolio. You can put anything you do, anything you're proud of, thank you presents from patients, and cards, anything. But applying for CST, you should base your portfolio on the self-assessment guide. And it's really useful. I wish I knew this existed in medical school. So everyone who's here at medical school, you need to look at this, and it's so useful to know. You can start prepping things now or yesterday. Use your time wisely and try and score in every section, and make sure your evidence is completely bulletproof so that no one can argue with you. So this is the self-assessment guide. So if you haven't heard of it before, go and look it up, read about it tonight. It's really self-explanatory. I've put on the right here the different sections. So for example, MRCS Part A, if you've passed Part A, you get 3 points. If you've sat it but failed, you get 2. And if you haven't sat it, you don't get any points. And that's basically how the stratification of marks works in every section. So prizes, national, international prize, great, 8 points. A regional prize, 6, and so on and so forth. Things that are useful for medical students to start doing are teaching, getting evidence of teaching. If you're a 5th year medical student, get together with a bunch of your friends, set up a teaching session for the 3rd year medical students, do some OSCE sessions, and get a consultant to write a letter to say you did it, and make sure it lasts for 3 months. And then you've already scored maximum points in that section, and you haven't even graduated from university. Simple, easy. So that's what I mean about scoring in every section. Put that one to bed, and then go on to, oh, I can do a QI project. For people who F1, F2, I don't know whether surgical electives will be reviewed this year, because lots of you had your electives cancelled from COVID. So I don't think the 2022 self-assessment scoring guide has come out yet, because it comes out after the application. Don't get too het up on the logbook. I was advised to start a logbook at university just to start gathering cases. I did it, I lost the password, so I had to start again in F1 anyway. You only need 15 cases in your logbook to score maximum points in this section. So applying for CST is not about how good a surgeon you are. You could get 15 cases in your logbook by doing a taster week the week before and getting it signed off. People do struggle with publications, obviously very difficult to come by, and they're hard work, and they are a long time in the making. Leadership and management, useful to try and be an F1 rep or try and join as a BMA rep. They don't stop anyone being a BMA rep when you start. So that was what I did. Right. So these are the sections. Now you need to be smart with how you're going to get your points. You might as well play the game. Everything is laid out for you. There's no secrets. You know exactly where you're going to score your marks. So this is an example. If you've done a PhD, if anyone listening has done a PhD, amazing, well done. I hadn't done a PhD. But by doing a PhD, you're going to score 4 marks in this section. A PhD is going to take you 4 years to do, but it's good, and it's going to score you 4 marks. Whereas if you decide to do a quality improvement project and present it nationally to any conference nationally, you're going to get 11 points and you score maximum in this section. So it's a no-brainer. Don't do a PhD before CST, do it after. You'll have to do it at some point. Do a QI project and present it nationally. One thing they changed this year, which scuppered quite a few people and they ended up losing 11 marks, was this move away from audit towards quality improvement. That means they don't want you to just do a simple audit in the department, put up a poster and say, oh, look, everyone's now doing something better because of my great poster. They want ongoing sustainable change. So the QI project that you did, you either need to do more than 1 complete audit cycle, which means not completing the loop once, but completing the loop twice. Or you can pick up an audit in the department that's already been done before. It didn't specify that you had to do every single round. So you just have to have been involved in something that is always being reviewed and being improved. So easiest ways to do that, if you're a medical student, is go to your surgical placement or your medical placement. Sometimes it's easier with medical placements, actually. My one was medical. And say, do you have any audits that happen annually in the department? And then say, please, can I get involved in it? then get involved in it, and then submit an abstract to a random conference somewhere in the UK. And then it counts as national. People accept anything, especially if you're a medical student, because you've put the effort in and less people present things. If you're an F1, F2, do the same thing. Say, have you done an audit in the department last year? Can I do another one? So yeah, read through the book, think about where you're going to score. When you've got maximum points in one section, move on to another section and work through. I had a document, I've got my folders on my computer since F1, which has every single section, and I just put evidence into each folder as I go along. Okay, that brings us on to evidence. I can predict already, and I can't even see the questions on the chat, and that happened last week and the year before, and the week before, people say, oh, I've done this, does this count towards getting this points? If there's any ambiguity and you're not sure that you're going to get the points, you're not going to get the points. You need to have absolutely bulletproof evidence, because when a consultant is marking your evidence portal and he's done 100 already in the day, just make it really easy for them. So this is my example. This is what was on the last one. So quality improvement project. Says, I played a leading role in the design, blah, blah, blah. So this is what my letter from my consultant looked like. And I quite literally put in bold everything that's on the mark scheme. So there was absolutely no ambiguity. I even got him to add on that it's ongoing sustainable change. So, sorry, excuse me. When there's a consultant marking this, they go, yeah, this student has done this, 11 points, tick, move on. You don't want them reading through a letter and going, because it's just going to annoy them. Make their life easy, then they'll like you and they want to mark you. They do want to give you the points. So the evidence portal was new this year because of COVID. Everyone used to walk around with these massive binders of all their evidence and be very, I'm surgical and amazing, here you go. And people would bring it along to their interviews and try and scare other candidates by the size of their binder. So that's all gone. And instead, luckily I had a screenshot, because it's not up anymore, of my portal. So every single section in the self-assessment, I then had to upload a document to defend the score I'd given myself, and that a consultant would mark this. So I tried to make it as easy as possible for them. So this is another example of one of the mark schemes. So the section is on the left that you're uploading evidence to, and then you had to title the evidence, and I quite literally titled it what it says on the mark scheme. So here you go, I've worked with local tutors to design like national, it's gone over 3 months, and I've got evidence of formal feedback, and then these are the titles of the evidence. So a consultant marking that has gone, yeah, they tick, 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 easy, move on. You just, end of the day, make their life easy for them. So that's a quick swift through the self-assessment guide and portfolio. Are there any questions at this stage, Jen?
Thank you, very useful already so far. The questions, first one was, I think that was from me waffling on about you at the start. What do you mean if you didn't get a surgical rotation due to COVID and getting redeployed?
So yeah, I had all my F1 and F2 surgical jobs cancelled, and I still managed to get a CST job. Coming in and being a CST day one, CT1, they don't expect you to be excellent at operating. They expect you to be safe and know how a theatre works, show that you've been into a theatre a few times. So obviously use your taster week. I had, you also have self-development time, which I think I mentioned later, that you can use on F1, F2, and I went to ENT theatre every Tuesday afternoon, and if you know how a theatre works and what's expected of you, you don't, like, F1 is essentially your secretary for the whole year. So I mean, it doesn't matter really. It's nice, and I would have preferred it, but I spent the whole time in ITU.
Very good. I was just going to say, just a quick reminder to everybody, if you can put the questions on the Q&A function, it's a lot easier to track rather than on the chat function. A couple more. Is there an expiry date for any forms of the evidence, or is it possible to do anything too early?
Absolutely not. If you can do anything. I found there's a section on training in teaching methods, and this year the top scoring section, they expanded it from 3 days to 5 days. And I'd done a course. If any of you are near Imperial, Mr. Anakwe does this course every year for people applying for CST. Because they changed it from 3 to 5 days, we were all scrambling around to get evidence for another 2 days of being trained how to teach. So I found from like 2013, we had a course at Leeds that was a few evenings a week. I found the cardiologist, emailed him, said, do you remember me? And he wrote a letter for me and it was accepted. It doesn't matter doing anything too early. Obviously, you can improve your evidence and choose your best evidence. You might as well put your best evidence forward by the end, but there's absolutely no time limit on it. So starting early at med school is like the best advantage you can get.
Fantastic. Another thing just to clarify is, how did you do a surgical taster week, or what is that?
So a surgical taster week, you have a dedicated study budget when you're an F1, F2. F1, I actually don't think you have a dedicated study budget, but you can steal from your F2 year. And that's one thing I wish I did, was a study, a taster week in my F1. Basically, you say to your rota coordinator on whatever job you're on, I'd really like to have a taster week I did mine in major trauma. And if they say okay, and the major trauma team say okay, you basically go and have fun on major trauma for a week. And you also don't do the ward jobs. You go to theatre. You're not there to work and do service provision. You're there to learn and see if you like it as a job. So my advice would be, if you're an F1 currently, try and get your taster week this year for 2 reasons. They never remember your study budget for the second year, so you actually don't steal from your second year. And you get an extra taster week, and then you can do one in F2. It's always really easy when you're on jobs like GP. Sometimes if you're on acute medicine or something, it's more difficult.
Well, and just to let everybody know, on the chat function, it's a bit further back, but I've posted the self-assessment guidance that Alice was referring to there, so feel free to have a look at it. I don't know, Alice, would you prefer to carry on with questions? Everybody's got a lot of questions now, or a couple more, and then
go for it. I'll try and do briefer answers. And
then... No, that's fine. Any advice about setting up teaching sessions as an F1?
Yes, find 2 or 3 friends and just do it. You can teach, you don't have to teach med students, because that's often quite well covered by the clinical fellows. You can teach nurses, and nurses are actually people who are really grateful for teaching, and you can do it as bedside teaching. You can do it once or twice a month. Chat to your consultant, chat to your nurse in charge, see if there's anything you can do. Just get a few friends together. And honestly, I mean, medicine's made up of teaching, so
absolutely would agree with that. Any advice on leading a QI or audit? How did you come up with an idea that worked? I think you answered this already in your talk, to be honest.
Yeah, QI, because it's sustainable change, there's an audit lead at the head of every department. That's the easiest way to find out what's going on.
Perfect. I think a lot of these, I'm going to refer people back to looking at the guide, because again, as Alice mentioned, if you're questioning whether yours may or may not work, either look in the guide, but if you're questioning it, if you can evidence it well, I think great, but if you can't, it's probably got to find something that's stronger. But I will do one more for now, and that will say, just because it can be a bit confusing about more than one completed cycle, and does that mean that you have to collect data, put an intervention and collect data again? Do you have to all do that yourself, or can somebody else do it and you do one of them?
So you can do it with a friend. It doesn't all have to be down to you. My one was actually quite a lot of work. But I didn't realize it was a QI project. That's why mine was difficult. I basically rewrote the F1 rota and had evidence before and after that mine was better. And because they fiddle with F1, F2 rotas quite frequently, that's why it was sustainable change. A completed audit cycle means you measure something, you make an intervention, you measure it again. So more than one means that needs to happen that whole cycle needs to happen more than once. So for example, are they doing too many CT heads in A&E? Because we're not actually finding anything on them. So do an audit of A&E, how many CT heads they did in a week's period, then how many showed an actual bleed or something. then you should do a teaching session to the department, or say to the department head, oh, I think we're doing too many CT heads. Maybe we put this questionnaire in, and we could do a couple of other things or something, speak to the consultants, then reaudit it, see if there was any change. I think that one is done quite frequently. So that's sustainable change.
Fantastic. Final one for the portfolio questions, and then we can always, if we have time, to do some more. Do you think the evidence portfolio will continue the way it's being done now because of COVID?
Yes, I think it means a lot less manpower for those marking. They can sit at home and do it, and it's quicker. It means that less trawling through, saves the environment, less people printing out giant portfolios. So I think it probably is here to stay. It's just
brilliant. Okay, we'll, if we have time, we can answer more questions, so keep them coming. Any ones I can answer, I'll go as Alice continues.
Yeah, no problem. Okay, I mean, most people on here are med students, so the portfolio probably is the key bit you want to focus on anyway. But it's nice to know about the interview, because I had absolutely no idea about this till about a year ago, just before we started. And then obviously it became my be all and end all for a few months. So the important thing to remember about the CST application is there's no surprises, there's no curveballs. It tells you completely what's expected of you. So there's kind of no excuse not to be prepared. And just like the self-assessment, there's no surprises there either. So you know what's expected, you know how to do well. So a few tips. Think about your virtual interview setup. This probably wouldn't be excellent. Too many bits going on. When you do interview practice, do some with a friend via Teams. I was told that I looked like a homunculus when I speak with my hands over camera, and it was really useful to know before my interview. So think about your virtual setup, your lighting, everything. Make sure you dress smart and you smile. Important if the interview is in person or not. Know the format and use it to your advantage. So that's what I was saying. It's quite literally written down in black and white, and it's the same for everyone. So I'm going to go through the format, don't worry, because most people won't know. And revise common questions. I was told about a few books that were good. This book was like the Bible for me. It has pretty much every single question that's come up in the past, and how to answer it and how to structure it. And it was the most useful thing. And you can speak to people in the years above you might have spare copies if you don't want to buy one, or share with your friends. And then basically it comes down to practice. So find a buddy, speak to yourself in the mirror, but make sure you're speaking out loud. Thinking in your head, you sound way worse when you actually speak out loud. So the interview counts for 2/3 of your total score for CST application. So your portfolio is one, and then the other two are made up of 2 sections. So 10 minutes on a clinical station, and then another 10 minutes on management. It is so quick. The interview is over in a flash, and it'll have gone by and you won't have realized. So all that work you're doing on your portfolio from medical school till now is worth the same as 2 10-minute stations. So it's important. Right, the clinical station is essentially 2 A to E scenarios. There are common stations, so like this book, they're all in this book. Common stations are really common. Trauma is common, and post-op, so CRISP. I don't know if anyone's heard, you might have heard of CRISP. It's a course you can go on. Then post-op situations that are quite common are like abdominal pain, low blood pressure, low urine output. The nurse rings you with one of these scenarios. So these are all common. You're more likely to get one of these. There are less common ones that come up, like tonsillar bleeds and leg erythema, which is usually neck fash or something. But essentially, the format to answer them all is the same. And I guess 2 main points are the interviewers want to give you marks. So if you go off track, they will interrupt you and bring you back because it's so pushed for time. If you are on track, they will kind of give you nothing and just stare at you, and they will not interrupt you if you're on track. I think my interviewer said barely anything in between the clinical scenarios for me. So I wrote down, for the ATLS, I wrote down a textbook answer of ATLS, and depending on whether the patient came in with shortness of breath or abdo pain, I slightly changed it. But I would literally rattle off a perfect ATLS with I'm looking for surgical emphysema, then I would palpate the anterior lateral chest walls, then I would auscultate and looking for any signs of any pneumothorax, hemothorax, and I would say it like that so that the consultants knew what I was looking for, and they don't give you findings. If they give you findings, they've made them up, and you're wasting time because you're then thinking about findings. They want to know that you're going to be a safe doctor, day one, CT1. So if you do a slick A to E, that's all they want to see, essentially. So an example is, they say, you've been called to review a 6-year-old male on the ward with hypertension. How do you proceed? And that's basically all they give you, and then they look at you like this. So my format and my way to do this was, if I was a consultant, I'm going to listen to 100 billion people rattling off an A to E all day. So how am I going to show them that I'm safe and I'm thinking about things? So at the beginning of every scenario like this, I'd go, okay, whilst I'm on the way to the ward, I'd ask my nurse to get an up-to-date set of observations, get the patient's notes out, and I would be thinking of differentials. I would be thinking of bleeding, sepsis, cardiogenic shock, anaphylaxis. Every single presentation that's in that book that I showed you, I would have 4 or 5 differentials, and I would front load the question. So the consultants marking me already know that I'm thinking of the bad things. I'm not waiting to get to see that they look a bit sweaty and then I might think of sepsis and doing buffalo. I've already said that I'm thinking about it. So they already know that I'm thinking about it. I've ruled out the life-threatening stuff. So quite frankly, when I go on to, so I've said that, then I'm rattling off an A to E as fast as I can, because they're not going to interrupt me, and it's a tick box exercise. They'll probably fall asleep as you do it. Then you say bloods, and you say all of them, because unlike at placement where they'll ask you why are you ordering all these bloods, you can have them all in your interview. Yeah, I'd like them all. I'd like every single blood you can do. And then you can have any scan you want, and there's no radiologist to vet them with. You can just have them all. So again, rattle this off, know the kind of one for each one. And then it comes onto your management. And if you've got your management, that's great, because they haven't, if you've missed out a few bits, they might ask you some questions. But if you've got something slick that you've written, they won't do, and then you're onto the management. Myself and Arjun, who's also on NSTS, who came top 1% of this, who I ran this lecture past, both of us got comments. You do get feedback on your interview, and both of us got comments that well done, mentioned analgesia, because remember, this is your patient, and they're most likely going to be in pain because it's a patient that's unstable or something, bleeding or trauma. Then by CT1, they kind of want you to be able to do this A2E and everything. But when you get into this point at the end and your patient's a bit unwell, you go, obviously, I'd like to inform my registrar patient. If the patient, you think they need to go back to theatre, you need to consent them. And for a top tip of when you start your surgical job, this doesn't need to be said in an interview. When a consultant asks you to have you consented the patient, what they actually mean is have you marked them, booked them for theatre, consented them, and optimized them. That's what they mean by consent, not just have you done the consent form. So to show that you know how you're going to be a good CT1 day one, you go, I've told my registrar, I've told the anaesthetist, I've told the theatre coordinator, I've spoken to the ITU registrar in case we need a post-op bed, I've consented the patients, they're marked, they're booked, they're optimized, we're ready to go. And the consultants marking you will sit back, fall asleep, and give you full marks. There are some follow-up questions to the scenarios, which very few people get to. So if you've got to that, it means you've done this quickly enough and well enough that so you can start getting the high scoring marks. I think I had shortness of breath and someone started asking me about specific fat embolism management, but there we go. So I hope that makes sense. Clinical station, it's basically an A to E. You can say, you can order any test you like, any management you like. That book that I showed you, I can't go back now, has all the previous stations. So if you have some differentials for them, front load, have a good A to E, you can't really go wrong. And the clinical stations are made up, the 10 minutes, you have 2 of these scenarios. So it's usually like trauma and then a post-op. Right, that was a lot to take in, sorry. The management station, often people don't like preparing for it, and so it's the one that people don't do as well at, but it starts with a 3-minute presentation, which is great. You have 3 minutes to talk uninterrupted that you've prepared, learnt by heart. It is the best thing ever. You've got 3 minutes to completely, you're under control, you control that part of the interview. 2 minutes of follow-up questions. So obviously whatever speech you prepare, think through obvious questions that you might be asked and think, how would I answer these? Don't try and learn off by heart answers to them, because it comes across, when you're thrown and the question's not quite right in the interview, you can get a bit thrown. So in the presentation and 2 minutes follow-up questions are the first 5 minutes, and then you have a management scenario, which is the last 5 minutes. Common stations are you working with a drunk consultant, or there's wrong site surgery, you've made a mistake. And the way that everyone I spoke to answered these questions was using Spies, which I hadn't heard of till this time last year. So my question was this, I don't know if my thing's in the way there. Reflect on your experience of leadership when working as a team member and how this will be useful as a core trainee. If you're an F2 on the call and you're applying next year, this was the question for like the last 3 years. So it's not like out of the realms of possibility that no one wants to make up another one, and it will be this. So you can sit there, have a think about this question. What's a useful thing to do? Remember, quite a lot, medics in front of consultants, other people don't like bragging that much, or I find that I didn't like doing that much, but this is your 3-minute opportunity to literally say how great you are. So I kind of did this as, I set mine out as, oh, this was a good example of leadership I've seen in the workplace by someone else. This is how I think I've emulated in my life good leadership qualities, and this is why that's going to make me a good core trainee. The first one you write will be absolutely awful, guaranteed, and then send it out to everyone you know and ask their opinion on it. So previous CTs are quite useful because they've just gone through it, and then junior regs, maybe less so consultants. But I mean, whoever you'll get to read it can read it. And then learn it off by heart and say it in your sleep, say it in the shower, say it on the way to work. I'm pretty sure my mum, my friends, and my housemates knew my speech off by heart as well as I did, because I said it so many times. This is also, for the virtual interview, the very first thing that happens. So you come into Microsoft Teams, you get put in a lady who checks your Wi-Fi, and then you go straight into the interview, and the consultant goes, please give your speech. There's like no small talk. So you go 3-minute speech, 2-minute questions, 5-minute scenario, 5-minute scenario, 5-minute scenario, out. They log out, they're like, bye. It goes in a flash. But this is your first thing. So your speech, learn it off by heart, say it well, put a sticky label on the camera of your laptop so that you look at it and not looking at yourself in the screen, which I've now realized I've been doing the whole time, sorry. And this is their first impression of you. So if you come off as like a competent, confident doctor, they're already going to start not listening and fall asleep. Then follow-up questions. I mean, I thought of loads and none of the ones I thought of came up, which was really annoying. So I actually end up using Spies, which I will come on to next, as a way to formulate a question and answer when I was in my interview. So Spies is a way to structure your answer of how you would manage a situation. So it's really useful whenever you're asked, oh, how would you do this or that? It's useful in placement, actually. So S is for seek information. So I'm going to do a working example next. So I'll go through this fairly speedily. So explore the medical situation, any colleague or patient concerns. P is patient factors. Patients always the priority. Safety for the patients always priority. For example, drunk consultant, there's no messing about seeking information. You go straight for patients on the table. Drunk consultant must deal with this first. Initiative. What can you do? Who can, as the CT1, what can you do? Who do you need to speak to for things you can't do? Who can you discuss the situation with? Can you already start things? Can you fill a rota gap or something? You know, things that are your level to fix. Then you need to know the escalation, and they will push you to know the escalation. They'll go, for example, there's a chest drain that needs doing in A&E. You are not competent to do a chest drain, but this patient's going to die without a chest drain. What do you do? Okay, I ring my reg. Your reg is busy. I ring my consultant, busy. Head of department, busy. Okay, I speak to an A&E reg, they're busy. Da-da-da. And they will push you and push you and push you until you ring the head person of the hospital, because they want to know that you're not going to put a chest drain in this patient if you don't know how to do so. So apparently you're going to ring the GMC to come down and get a chest drain in. Obviously it doesn't happen in real life. and someone around will do it, but they want to be able to see that you can escalate things appropriately in the medical world. So registrar consultant, within your MDT. So if there's a problem with the nurse, you speak to their matron, nurse in charge matron, and then staffing. Always good to know about BMA, occupational health, HR, just shows that you think more holistically about things. And then finally, support. Patient factors: do you need to apologize? Duty of candor: do they want to complain? Go to PALS. Colleague: can you support them? Do they need their supervisor? Whatever. And then yourself. And at the end of all these scenarios, I always said, I'd reflect on this situation, because they love it. Right. So I had a very similar scenario to this in my interview. So you've booked the wrong scan. Ooh, what do you do? So first you want to seek information. So chat to the patient. Do they know they've received the wrong scan? What was the right scan? Do they need the right scan? Make sure you document the patient understanding, blah, blah, blah. Basically gather information on what went wrong. If you put the wrong scan, was someone else meant to have that scan? Which comes into patient factors, really. So have you booked the wrong scan for a patient that actually another patient needed, and have either of them come to harm because of what you've done? If there's no harm, that's okay. You can take a little bit longer to deal with the situation, but it might be that someone needs an urgent angio before a PCI, and you're like, ooh, they didn't get it, and now they've had a heart attack. So yeah, check the patient's not dying or dead. Then take the initiative. You've booked the wrong scan. Go up to the patient, say, look, I'm really sorry. We're all human here. Rectify, apologize, explain, and reflect. Reflect comes again at the bottom. Really important. They ask you a few follow-up questions on this scenario. So if you haven't mentioned duty of candor, they're bound to ask you, what is it? Then escalate to your consultant or supervisor. Sorry, sir, I messed up. And then support. Does the patient want to complain? You can direct them to PALS. Reflect on the mistake. Is there an audit or a quality improvement project you can do? Did you click on the wrong scan because there's a problem in the system, and actually it finds out that loads of people have been doing the same thing because it's a systems error as opposed to a personal error? Then you could, do an intervention, do a QI project. Happy days. One thing I haven't mentioned on here is doing a DATEX. Useful to mention. DATEX for medical students is basically putting a report in for a near miss. It's just a form online that you put in. Nurses do it all the time to you if you don't ask your bleep, apparently, when you're in F1, but it's okay. Okay, whistle through of clinical and management, probably loads of questions. We've got there's only one more slide, Jen, so I'm happy to do like a fair amount of questions if there's any other portfolio runovers as well.
Fantastic. Yeah, I might do a few portfolio. I referred a lot of you to the handbook. So if you can't find your answer in the handbook, we can always try and help, or Alice can try and help later on. Yeah. It's just so useful to read through, and it is actually really detailed and thorough. So I would just read it before you are worried, because that will probably answer it a lot better than we can. However, some interview questions. So one is, does every applicant get an interview, or is it just applicants who have passed the portfolio phase? Do you know? So
it's only applicants who've got through portfolio. So the bad thing that happened this year is there was a very high cutoff for score. So you self-score yourself, and then they cut off from that. And then you have the opportunity to give your evidence. So people actually ended up getting scored down below the threshold. So there's a bit of argy-bargy about that. But anyway, score yourself correctly and then you can't get into trouble.
Fair enough. Yes, and that linked me back. Somebody said, can you put on things on your self-assessment that you haven't yet got evidence for? I said,
no. So they're really strict about this. The evidence has to predate, I think, the application. So, or the evidence, it might be the evidence portal opening, because I had a course that just went into December and that was fine. But by the time you've given evidence, you can't retrospectively give evidence, or I promise you my publication is going to be published by the time of interview. Doesn't count.
Yeah, and that goes for everything before deadlines. I'd just be safe than sorry, because you risk losing, as Alice mentioned before, all of those points in that category if you don't do something right. So yeah, fantastic. Okay. There was a question about how long did you prepare for the interview for?
So I would say I had 2 friends doing the interview as well this year, and we all scored pretty similarly. So I think we must have practiced the right way. We just did it a lot. It was kind of more intense preparation, probably for about 3 weeks, maybe. I did my exam, part A, near the time, so my knowledge base for the clinical scenarios was actually all pretty good as well. So if you're planning on doing exams around interview, that's quite useful in terms of you do know what you're talking about.
Someone just asked to go back to the slide with the book so they can make a note of the book that you
Oh
use.
yeah, the book is excellent. I think it is like 30 quid though. It's a bit expensive.
Everybody can take a note of it or try and get a PDF of it somewhere. So any suggestions for any courses that you did that count and are low cost?
So the National Catheter Education Programme is not only free, but doesn't take very long. And for some reason it counts for points. So I think pretty much everyone has done it. So I think if you Google National Education Catheter Programme, it comes up and it's free. And it's the most bizarre. You have to watch some really strange videos about catheters, but you get a certificate at the end and that one counts. The ACIT, Introduction to Surgical Training, is a good one. I think also fairly cheap, but I think I had some pretty low budget courses on my application. Definitely those two. Basic Surgical Skills is a good one and a useful one, but it does cost money. So you can only get funding for courses in F2. So I did my ATLS in F2, but it was too late for the courses for the CST application.
There's somebody just talking about virtual interviews and going straight into I'll read it out. You mentioned the format of the virtual interview, i.e. going straight into the management presentation first. Can you briefly explain further about the timing of each station?
Yeah, no problem. So what happens is you get given a slot for interview time, you go on to Teams, you start sweating profusely because you're really nervous, and then you get put in a room with a really friendly lady and you think, wow, she's probably my interviewer and she loves me already, but you realize she just checks your Wi-Fi. And so you've set up your camera and you're on Teams with a lady talking to you, and she asks you have to basically rotate your laptop around the room to check there's no one there. And then you sit with her awkwardly for a little bit longer until your markers are ready. And she will then add 2 consultants into the call and go, bye, Alice, good luck. And the timer starts as she leaves and a consultant will go, start your presentation. So the first 10 minutes is the management station. You do your speech for 3 minutes and they will cut you off at 3 minutes. So make sure with nerves and everything that your speech is actually about 2 minutes, 40 seconds, 45 seconds. They will cut you off and then they will do 2 minutes of questions. And then again, if you're babbling, they will cut you off again. And they will give you your management station, which is 5 minutes. So 3 minute talk, 2 minute question, 5 minute management, the Spies scenario. And then timer will cut and then they'll give you a clinical scenario and then they'll give you the last 5 minutes. And then there's no saying bye, they just log off and then you're done. And it's really strange and really, really fast.
That is very useful to know though, thank you. There's some just on training and teaching courses. So for the training and teaching, somebody asked, can you do 2 separate courses and combine them to make 5 days? Yeah,
you can definitely do that. Training and teaching is quite hard to come by actually, and sometimes you have to pay for it. If anyone is London based in Northwest London for F1, F2, Mr. Anakwe's the Imperial Teaching in Clinical Practice course is kind of specifically designed for this purpose because it's consultants, surgeons doing it for us. And that's 5 days. So if you're around London, that's quite useful. Otherwise, just Google them. But you can, yes, tally up 5 separate days.
Brilliant. That's great to know. Thank you. There's a few about the interviews and your scores. I don't know how personal you want to get. Do you know what the cutoff was at interview and what your
I don't know the amount out of. I think they're all out of, I really can't remember. They're either out of 90 or 70 each portfolio. Oh my God, it was only a year ago. I really can't remember. I'm really sorry. I have absolutely no idea what the cutoffs are. The cutoff for portfolio was, maybe they're all out of 70. The cutoff for the portfolio for interview this year was 48 out of 70, which was much higher than it has been in previous years. I think quite a lot of people weren't going away for COVID this year, so there was a really high intake of applicants. The interviews, there's no real way of knowing what the cutoff is, to be honest.
And someone asked what yours was, but you don't have to tell us.
I mean, I can find out if we need.
No,
I'll find out.
That's fine.
You can put it in the blurb under the video when we upload it. I'll find out. I can't remember. I've got my PDF somewhere.
This is kind of in connection with what you've just mentioned about, did the most successful CST applicants take a year out of FY to enrich their portfolio? Would it be disadvantageous to apply straight after foundation years? Well, you applied straight after.
So there's pros and cons to both. I guess I put this on the first slide. F3 is really valuable. Some people just need a break. Some people have personal reasons to do it. Some people want to do a specific, we have a friend who's doing cleft palate for 6 months. Like, it's so niche, she's really enjoying it. But I knew CST was competitive, so I went straight in with my application and did well and was like, oh, well, I'm here now. And I think it happens to people a lot. Pros and cons. You might end up taking a job that you didn't really want. If you do CST the first time, you go, oh, I'm in now, might as well. You might do a job that you then again, doing a locum for years might not be that useful. The reason not to take a year out is because if you take too many, it starts counting against you as a registrar. In between F2 and CST doesn't really make any difference at all in terms of the application, and you're probably a better applicant. But if you start taking too many years out, like you enjoy Australia too much, then it's going to be harder to get a reg job. I think that's the only thing against it. There's loads of opportunities to do really great things.
Fabulous. Some people are just asking if you can just repeat the name of the professor at Imperial who does the teacher training course.
Oh no, if you it's a few consultants that do it, but if you Google Imperial training in teaching course, it'll come up somewhere. Right. It's advertised around November. It's on an Eventbrite page, I think.
Fabulous, that's very helpful. Anything about location of CST depending? How, I guess you briefly touched on this at the beginning, but was London specifically competitive, and how does it depend where you get?
So I think they sometimes release the competition ratios, but I actually, because I was always doing this, because I was always intrigued by this, because I was trying to figure out my statistics of getting into London, but the stats are actually quite hard to find. It's just like when you apply for F1, everyone wants different things. So just go for what you want for and work really hard, and hopefully you get what you want for. And if you don't get what you want, you might end up with something you didn't realize you wanted. So I'd say just go for it.
Fabulous. We're nearly there, and you can move on to the next slide. Somebody's asked, for somebody in a trust post that just started working in the NHS, is there an e-portfolio that you would recommend?
So we have to do ISCP, which is really expensive, and I don't like paying for it. So I think just my portfolio was just documents on my computer. I had a title folder for every single section, and every time I did something, I'd bung it into each one. And that's probably the best way to do it. But for logbook, use e-logbook, and you just Google the letter E, logbook, and that's free.
Someone has asked, when's the best time to take the MRCS, which I believe it comes onto your next slide.
Yeah, so let's go over. So
on by magic.
This is the last slide, don't worry, and then we can do any questions if people want. So the end of CST, the main reason I have them both out the way is because it was COVID. I didn't mind revising whilst there was nothing going on. By the end of your CST 2 year, you need to have completed both of these exams. There's the main advantage for getting them done out the way in F1, F2 is that I can now focus just on my portfolio stuff. I don't have any exams hanging over my head, which is quite nice. People also tend to let you do things more if you say I've passed MRCS. They are expensive. They're expensive exams, and you do not get money back for them. You do get tax back for them. So make sure you make a note of it and claim your tax back from the government. So part A is £550. It's really hard and 30% pass rates. the best advice I've had for it was just do loads and loads and loads of MCQs. So learn your anatomy, go through your old anatomy notes from uni, and then I did EMRCS, and I went through it 3 or 4 times before my exam. So I kind of knew the questions. I didn't do Pass Med because I actually wanted to, it's slightly more expensive, and I wanted to keep a question bank in the bank, as it were, in case I failed. So some people do both, but you have to pay for them both. EMRCS is slightly cheaper, and I thought it actually mirrored the real questions more. Part B is even more expensive, and that's the OSCE. It's best to do this with a friend because you have to practice speaking in examinations. There's past accounts you can find by Googling, and past the MRCS is expensive, but, and I thought it wasn't too good. But then when I actually did the real exam, I realized how relatable it was to the actual exam. So that's an expensive but useful adjunct. So yeah, expensive. So I would do them. MRCS Part A, some of your knowledge from finals is useful. So people say if you do it near a finals, that's better. Don't do it when you're on A&E because it's horrible to revise when you're on A&E. I did Part A when I was on GP, and I ended up, COVID cancelled my second one. So I was meant to do my Part B when I was on surgery, but surgery got cancelled to ITU, and then exam got cancelled. So I ended up doing my Part B on A&E, and I would not advise it. So I would try and get Part A out the way in F1, F2 would be my advice in your community placement, and then Part B when you get a chance. There's no real stress to get it done. So kind of in summary, but I'm happy to answer more questions. Familiarize yourself with that self-assessment guide. That's probably the most useful tool you have. There are no hidden questions. There's nothing hidden about the CST application. It's open, it's transparent. You can prepare for it. There's kind of no excuse not to do well if you start early. Make sure you collect evidence. Try and collect it as you go along. Emailing consultants 3 years later annoys them. Develop a structure for clinical management stations and stick to it, and just find friends and practice with them. And good luck to you all. If this QR code, if this lecture series has been useful for you, or you want me to do, I am happy to do a session just on the portfolio. The only reason I didn't read through it is because I didn't think people found it very easy. But if you would like a session, just mention it in the survey, and we're happy to arrange one. I will also, whoever's on the Q&A, do you want to put my email on? And I'm happy to be emailed about anything. It's alice.gargan1gen@nhs. Whatever it is.
Maybe read the portfolio first before.
Okay. But no, I am happy to be contacted.
No, she's very.
It's absolutely fine.
alice.gargan1@nhs.net. It is on the chat.
Yeah, so my email's on the chat. Let us know what's useful for further sessions. And good luck to everyone. And amazing, so many people from med school came because
thank you so much, Alice. Thank you.
I'll do one final thing for those who came from medical school. If you haven't decided between medicine and surgery yet, firstly do surgery, but secondly, the self-assessment guide is really similar format to medical applications anyway. So doing things that are going to score you on the surgical application are most likely going to be transferable if you decide to do medicine or anything anyway.
So yeah, all around. And if you are still here with us, please give us your feedback. Not only is it super useful for NSTS, but it's very useful for Alice to have, and to thank her for her time in her busy life giving up to teach us all. If anybody still wants to speak about more questions, we can carry on.
Yeah, I'm happy to answer a few more.
Yeah, fabulous. We'll do a few more. Somebody just said, could you explain or just go back to the acronym for management in the clinical scenario station? All these lectures are recorded too, so
yeah, they're all recorded. The acronym for the clinical one. Oh, Mark Book Consent Optimize. Yeah, it's not an acronym. I just bolded the letters.
Very good. You can go back to your feedback slide now. I have put the email ID for the next person on the chat, but it's alice.gargan1@nhs.net. The next question is, how does it work with being given a job after core surgical training? Can you apply for multiple locations and specialties?
For registrar training? Yeah, you can. Even for core surgical training. So it's not quite the same as, I should have mentioned this, that's so silly. It's not quite the same as F1. F1, you rank all your deaneries, but core surgical training, you rank all the jobs in the country. So if you really want to do orthopedics, you can rank all the orthopedic jobs from Aberdeen to Portsmouth if you want to. You're not constricted by deanery. Then for Reg training, I think it's much this. I think you have to apply for deaneries, but I think you can apply for more than one deanery. And then slightly more flexible. I don't think they track if you apply for more than one specialty, if you're going to throw your eggs in all the baskets. But I can definitely find out and we'll probably do a session. It's slightly out of our remit of NSTS, isn't it?
Yeah, it's going above and beyond, but maybe we have scope for the future as we grow up.
Yeah, we'll get on.
Next question is there any value in doing a PhD during medical school? I actually missed this one from earlier, apologies.
Oh, wow. I mean, the only reason I can think of doing a PhD, no, I can think of like three. One, you might be really interested in something. And so by all means, go and do a PhD, because why not? If you have the funding to do so and you love uni, why not? The benefits of doing a PhD when you're a little bit more senior is you have a bit more knowledge behind yourself. You probably can do a bit of locuming on the side to support yourself financially. So it's a tricky one. It's personal preference. I wouldn't have had the money or the wherewithal or the knowledge to do it then, but I probably will have to do one at some point.
Amazing. And somebody just said, any tips on how to figure out if surgery is for you?
Yeah, if you're a medical student, get stuck in on your medical placements. I mean, I remember being on my medical placements at uni being a bit of a spare part, which is, so go along and make yourself known and find a junior. That was my tip. I love it when we get med students in, and I'll take them with me around all day, because then you have a friend, so it's great. And say that you're keen, scrub in. Get taught how to scrub and scrub in, because if you're scrubbed in, you're going to hold something, you're going to cut something, you're going to do something. If you are observing from the side, you are so not engaged and you will so fall asleep. And so get stuck in. If you're an F1, get your taster week organized early. And if you're an F2, do your taster week. It's the best thing.
Really good advice. I think that is all of the questions.
Perfect.
We've got through. Lots of thanks, Alice. And I repeat that again, just it was incredibly informative, really useful. I'm really sorry, I realized that I was just messaging myself. My message is on the chat for the general. So alice.gargan1@nhs.net is already there, and NSTS has put it too. And I've also just popped the self-assessment guidance for candidates on there as well. So I think that should be it. Thank you everybody again for attending. All of these lectures from the 3-part webinar series can be found on our website. They've all been really useful for medical students, F1 and F2, and then for going into core surgical training. And to be honest, they're useful for surgery or not surgery, depending on what you know. So thank you very much for attending, and have a lovely rest of your evenings.